Yeah, hi, my name is Elijah. I am a PhD student in clinical psychology over at the University of Mississippi. And this is my project just based around delivering chronic pain therapy to a very chronically underserved area. So Mississippi has high rates of chronic pain, some of the highest in the nation, and also the lowest availability of providers within the nation. Something called the brain drain, where people get their degrees in Mississippi and then they go somewhere else. So all that ability for psychologists, doctors, physical therapists, it's greatly reduced. And this is magnified within rural areas where someone just doesn't have a provider in their town. They don't have a lot of electric access, so they can't do any form of telehealth. So people who have injuries and a lot of rural living, say from a farm accident, personal injury, slips and falls, what have you, their choices are to maybe live with it, maybe some advice from the internet on how to deal with chronic pain, getting a short-term prescription, which always runs out because of prescription limits on things like opioids, turning to illicit sources of opioids, trying to get some kind of relief, or ending their life. And having chronic pain is a very high risk factor for someone dying by suicide. So my hope for this was to find very accessible ways for people to receive behavioral health therapy. Behavioral health is really just the things you do, trying to address different health conditions. What actions can you take alongside whatever a doctor prescribes, a medical doctor, to try to address that? A larger hope for all this was to really leave a generational impact on health treatment and treatment access within Mississippi. Specifically for chronic pain, someone who experiences chronic pain relating to a car accident some years ago. And I was able to access services because I lived in Oxford, Mississippi, a very well-to-do college town where if someone does get their degree in Mississippi, that's where they tend to stay. A lot of people don't have that kind of access. And so I wanted to at least disperse equity as much as possible. So the process of creating this chronic pain therapy program had four key steps, each of them unique and important in their own way. So because I was doing this through the University of Mississippi psychology department, the biggest part was getting the policy manual approved. As psychologists or graduate students training to be psychologists, there's state standards, legal standards, university standards, and then also psychology as a profession standards. So creating a policy manual meant that everyone who took up the program and generations after me had a very well set code of what they're doing and how to do it, just eliminating a lot of the guesswork. It was a key process for approval and took the longest, close to 2 months, and I think 8 rewrites because of having to navigate all those different standards and getting it all into one document. The way I got through that was actually by Occam's razor, which is one of my favorite words that I learned in high school. In essence, it just means less is more. So it went from close to a 60-page document to something like 10 or 15 pages because I realized with all these existing standards, a lot of the ethical principles were already set. So I could just say refer to clinic manual from the University of Mississippi, refer to principle A from the APA ethics code. That way people knew what to refer to. And the core content of the manual was really just what needed to be known specifically for this pain therapy program. So less was more. If I had known I could write less at the start of it and get this manual approved, absolutely would have done it. So after that was teaching graduate students chronic pain therapy. So this is a very specific type of therapy. Usually when people think of mental health, they think of anxiety, depression, schizophrenia, bipolar, a lot of the personality disorders. They don't think of how therapy can really help with health conditions. And this is even students getting their PhD. They had no idea. So because it was the area I specialize in, I created a series of workshops with 8 graduate psychology students teaching them how to deliver this therapy, conceptualize how maybe something like chronic pain can interact with depression. The more pain that you're in, the less you're able to do, bigger sap on your energy. Depression symptoms tend to foment. There's a lot of comorbidity between them. So there's a lot of active teaching strategies, getting them to learn what to do, how to do it, and then also practicing it with each other in role plays. And so from that, I trained 8 students. 6 of them committed to taking patients with chronic pain across Mississippi. There was a unique opportunity to do this because there was close to $2 billion in federal and state grants looking at there's delivering digital infrastructure to rural areas. So those areas that have never seen internet access, all of a sudden getting the towers in, fiber optic cables, whatever you want to call it, so that they could finally access the internet. And even if they're in a rural area with no providers, being able to see one through telehealth for the first time. Then it was connecting with doctor's offices for patient referrals. And so usually someone with chronic pain will go to see their doctor and they'll get a opioid prescription, something like that. It runs out and they're just given well wishes, told to do the best they can. This created the opportunity for doctors to refer people to us, especially for free therapy pro bono, because a lot of people, especially in one of the poorest states in the union, couldn't afford therapy. So knowing that there was a free option available that could complement providers' care is fantastic. It took some good flyer disbursements. A lot of my time at this point was spent on just creating the flyer, coordinating with artists, getting all the essential information in, getting it approved, visiting these offices in person, having lunch with the doctors, explaining what the program's about, and getting approval. So those are the three steps I've done so far. The last step that I'm on right now is I'm actually creating a poster for psychology conferences so that we can disseminate what we learned, teach other programs how to do the same, because chronic pain is not only localized in Mississippi, it's something occurring everywhere. So outcomes from this policy. So I wish I could show you pictures from the workshop. I was advised not to because of the Family Educational Right to Privacy Act. These were graduate students who were taking the workshops as part of course credit. I never got explicit consent to photograph as part of it, and so I was advised just hold off on that. However, there have been commitments by 6 of the 8 graduate students to take on patients, at least 2 patients, and they have the knowledge now of how to actually teach other graduate students in chronic pain therapy. Policy manual, that big Moby Dick-sized whale that took so much of my time, has been created. It's legally valid. It's something that they can all use going forward. The connections and the referral network with the doctor's offices have been created so that there is true wraparound health service in this area and in the larger Mississippi area. People have already signed up for the wait list to receive therapy and have been connected with providers. And right now I'm just making that poster to disseminate at conferences so that people know how to do their own thing in Mississippi, Florida, and beyond. So looking at next steps, I've already established multiple generations of people who will carry on this project. They have the manual and they have the advisor, the doctor who helped me establish a program. I'm staying on as an advisor as well for any policy connections, referral networks, just to make sure that this thing stays alive beyond me. And there's also talk of branching out to other conditions. Mississippi struggles heavily with diabetes. Again, it doesn't differentiate between any of these counties, it spreads out heavily. And so a large struggle with diabetes in Mississippi is that people can't often do the behavioral treatments alongside insulin. If someone can't establish a pattern of consistent health behaviors, that's often where amputation of toes, feet, legs, digits comes about because it's a life-saving measure. And at that point, it's often seen as the main thing someone can do. So the need for this to spread and grow towards diabetes treatment is very necessary and something I'm trying to support right now. My personal growth on this would just be I've always had a desire to help, and I never knew how. But this capacity to contribute as a psychologist was something I struggled with as I grew into this career. So being able to do that and finding a specific target for it, something that, okay, I want to help, but how? Chronic pain, trying to move the metric on that. It's something so meaningful to me. I'm glad I've been able to find that focus, as well as establishing the value of pro bono, free work. The free work that therapists can do that makes such a difference for people who can't afford it means everything to me. So in closing, thank you to the Newman Foundation, Allstate, Dr. John Young, University of Mississippi, and everyone who's involved in this in helping establish this and create it. My lunch break is about over, so I don't know if I can stay for question time, but I also want to thank you for your attention today.